He's a Harvard-educated doctor. He did the very first clinical trial in the United States for acute stroke. There's very few of those taking place. Over 800,000 people a year are disabled by strokes. Are you kidding me? And there's no drug for it? That's not good, not good enough. So what we're going to do is we're going to support Dr. Savitz. And the way we can support him is to help him get funded properly. He's now working on it. He's worked on a trial. He's trying to reverse the damage 3 days after a stroke. He wants to do it 19 to 30 days. We've got to help him. And so he's a wonderful friend of ours. He's a member of our medical advisory committee. And I couldn't be happier to introduce Dr. Sean Savitz.
That's really, thank you so much for that really wonderful introduction, David. You know, and I have to say it's just been a great opportunity to be able to work with you. I think that there's just been amazing progress that TSCR has made, really, over such a short period of time. And just also very thankful that so many had turned out tonight to be able to come to this kind of talk. It just goes to show you that this is building momentum, I think, over time.
Yes, sir.
So I'm going to talk about cell therapy for stroke. And this really is a discussion about what we've accomplished so far. And what I need to emphasize up front is that this is still very investigational. This is not a therapy yet. And that we are working on trying to see whether the use of cells, some of these are stem cells, could actually be used someday to enhance recovery from stroke. We've taken this as a story from animals and actually started the first clinical trials in the United States. And that's what I'm going to talk about tonight. So, I guess any discussion about stroke, and I have to be very careful what I'm going to be saying. Dr. Mark Goldberg is in the back, who's also a stroke expert. Anything that, I think any discussion around stroke has to start off with at least a picture of the brain and the blood vessels that feed the brain, because a stroke is caused by some problem that's occurred in the blood vessels that are nourishing the brain. And the usual reasons that we have a stroke is because there's a blockage. Louder? Okay. The usual reasons why there can be a stroke is because there can be a blockage in one of these arteries. And if there's a blockage, then the brain is simply just getting starved of oxygen and glucose and the needed nutrients to be able to continue to function. And the other reason is because the blood vessels may just rupture and simply spill blood into the actual area around the brain or in the brain itself. I'll show you that a little bit more in this cartoon of a slide. So if we were to slice the brain up, and this is what slices of the brain look like, this is the blood vessel here, and this is a blockage. This is a clot. This is the offending agent, so to speak, and this is the most common reason that we can have a stroke. This clot is putting this entire area of the brain at risk to go on to die. And that's really what a stroke is. And that the other type, which is less common, is that the blood vessel here just opens up, it ruptures and spills out blood into the brain itself. And these are two very different types of stroke and require two very different types of approaches for therapies. I always like discussing the importance of stroke from a historical perspective. So you thought that you were done, learning about this in your history textbooks. But actually, as a fan of history, I always think it is important to bring these things up. That actually, these three leaders, when they met back in 1945, it's theorized that by this point in time, they probably already were so demented from extensive strokes that they were having, and it was just really hidden from the public. But what we do know is that all of them died from stroke. So when Churchill, FDR, and Stalin were basically meeting and carving up their territories of the world and thinking about the post-World War era, it's just interesting to think about stroke from that global perspective. But kind of bringing it a bit closer in time to when we're living. Many of you may know that Senator Lloyd Bentsen as well, who was a senator of the state, he also had a stroke and he had died from his stroke, and he was quite disabled from it. So the scope of the problem is that right now stroke is the fourth leading cause of death. It's actually the second leading cause of death worldwide, And as David said, almost 800,000 strokes per year in the United States. Now people like the American Heart Association, like to translate that into something very dramatic. Every 45 seconds there's someone in the U.S. having a stroke. But actually I think the more important point is for those that survive, it's the leading cause of adult disability. And this is how much money it had been projected that it cost to take care of patients with stroke in 2010. We have actually only one approved therapy by the FDA, and that's something called tissue plasminogen activator. This is a drug which actually helps to open up a clot. So I'm talking only about those strokes that are caused by a clot, a blockage in the arteries. You can give this drug if you can get a patient in time, and it has the chance that it will actually open up the artery. The problem is that you have to give it really fast. And by guidelines, one could consider giving it up to 4.5 hours after the onset of symptoms. But by the FDA criteria, it has to be within 3 hours. And unfortunately, only about 3 to 8% of treatable patients receive it. And we have no, I'm going to say, proven FDA-approved therapies for the majority of our stroke patients, unfortunately. So we absolutely, as a public health need, a public health demand, we absolutely have to find other therapies for stroke. And there's a lot of different approaches that people are looking at. This is just another kind of schematic just to show and putting it into a different kind of perspective. That imagine, if you will, that somebody is having a stroke and this is time 0, the onset of their symptoms. They start developing weakness, they can't move their arm, they can't see, they can't speak. This is 1 day after the stroke, and this is 1 month after the stroke. We have, over the past 20 or 25 years, governments, investigators, industry invested a lot of funding to try to find therapies that work in this very, very narrow window here. And we have only one approved therapy that works in this very narrow window. But now, there's a lot of studies out there suggesting that we may have other windows to be thinking about within the first few days, and that's where I want to kind of turn the rest of this discussion to. We may be able to use cell therapies, some of them being stem cells, as a way to kind of stimulate what's happening inside the brain in the first few days after a stroke. Stimulate active brain remodeling processes that start to occur in the first few days. Recovery processes that are starting up in these periods of time. Now you might ask, well, what do we need to do anything for if the brain is doing this by itself? And the answer is that, unfortunately, how we're designed, the brain doesn't do a very good job. Because if anybody's ever taken care of a patient with a stroke, they are usually, and often can be, very disabled from it. And it's because our brains are actively trying to repair, but it's very limited. And so the idea is right now, at least one strategy, therapeutic strategy, is to be able to use approaches that can actually enhance those repair processes. Now others, particularly in the laboratory setting, are trying to come up with approaches that maybe we can find things that could help stroke patients even further down the road, 1 month or several months after the onset of stroke, using stem cells. Those approaches are, I have to say, pretty far off in the horizon with regards to using stem cells. There are other approaches out there that people are looking at that look potentially promising for stroke that's further out in time. So I don't want to leave you with the idea that, oh, we've got nothing coming, but I just wanted to kind of give you the layout with regards to stem cells. They have a greater chance, I think, of making it to the clinical side in this period of time, at least the way we're thinking about their use right now. So why think about cell therapies? Because we haven't had any new treatments that have been approved by the FDA for 12 years or longer. Stem cells represents an opportunity because we could be thinking about a much broader window. Days compared to hours is like millennia in my field. And this is an approach that could protect the brain. It could do a number of different things, including reducing the post-injury inflammatory response, which likely contributes to ongoing injury after a stroke. It could inhibit recovery. And it also has the potential that it could actually just intrinsically help to repair brain damage. Well, stem cells, you've heard a lot about that in the press. The question is, well, there's a lot of different types that are out there. You've heard about embryonic stem cells, I'm sure, but there are other types of stem cells as well that can be isolated from brains, for example. Usually this is found in animals, but it actually can also be isolated from fetal tissue as well. And there are stem cells that can be actually isolated from a number of different tissues, which has led to a whole area called adult stem cells, where we're not talking about using stem cells from embryonic or fetal tissue. We're talking about using it from adult tissues, skin tissues, bone marrow, And umbilical cord, I wouldn't say that's from an adult, but it's actually labeled and folded under the category of adult stem cells because it's an alternative source of cells. This area in particular, more than any, has skyrocketed in terms of the amount of research which is going into trying to find new therapies using cells. And that's actually where we have turned to as well, because all of us are reservoirs that have stem cells inside of us, and in particular we're very interested about stem cells from the bone marrow. Interested from the bone marrow perspective because I'm not going to go through this slide in any great detail, but just to show you, this is actually femur of our within the legs, and there's bone marrow inside of it. This is the brain over here. And when there is a stroke, believe it or not, the bone marrow is releasing stem cells into the bloodstream. And those stem cells likely migrate up to the brain. Does it contribute in any significant way to helping patients to recover from stroke? The answer is we don't know. There are some very intriguing animal studies to suggest that hematopoietic stem cells from the bone marrow may actually get released and may actually participate in repair after stroke in animals. So, as an interest of mine, we were looking to think about what would be a practical approach to using a patient's own bone marrow cells, some of which have stem cells in them. Could we think about that as an approach for patients with stroke? I was very particularly interested in mononuclear cells because they are in the bone marrow and they're enriched with different types of stem cells, but they also have a lot of other different types of cells that are in them, I have to say. So it's really a mixed cell type. What's advantageous about them is you can rapidly isolate them from bone marrow and you can reinfuse them for autologous testing. Autologous meaning from the same person. And by the time I got interested in this, there's already several phase 2 studies that suggest the possibility for benefit in patients with myocardial infarction. A lot of that work being done actually down at Texas Heart Institute with Dr. Willerson. And so I was very, very encouraged by the work that his group and others were showing with these types of cells. But what really encouraged me was I started seeing, as I started investigating this in the lab, that other labs focused on stroke were also finding potential benefits in animals. And animal models are really, at least in my mind, the focal point to try to develop new therapies for stroke. That's really where R&D starts for new therapies in stroke. We actually have pretty good animal models, I would argue, for stroke. We can determine the safety of new approaches. We can determine whether they work, because, at least in the animals, because we can do testing on them. They are impaired by stroke as patients and humans can be. We can test those impairments and their disabilities in animals and see whether new approaches are working on them before we actually take something forward to patients. Also, the FDA likes us to be able to do animal models before we actually start testing patients. So I'm not going to go through a lot of animal data here, but just to show you just a little bit, and a lot of this data, particularly for anyone that's interested, I can go through this in much greater detail. I can send our publications to anyone that might be interested. So you might have to take my word for it, since I'm not going to go through the data in any great detail to spare people a little bit about this. But we actually were testing in our animal models, and this is basically what we do. We have a standard model for stroke in which we cause a blockage in the rat brain. And then, about a day later, we actually harvested the bone marrow. We took out these mononuclear cells, we isolated them out, and we gave them back intravenously. And we did a dose response in which we were giving different doses of cells, 1 million cells per kg, 10 million cells per kg, or 30 million cells per kg. And then we measured these animals for particular deficits and impairments that they have over time, anywhere from out to one day to 28 days after their stroke. And what all this data really kind of shows is simply that we saw a reduction in the impairments that these animals had when they received the following. They either received 10 million cells or 30 million cells per kilogram, but they didn't actually do as well if they had received 1 million cells per kilogram. And we found really the same effects no matter what kind of test we did. We found this really on 2 different tests. So this kind of helped us a little bit in terms of a dose response overall, like what kind of dose of cells do we think we can actually give to patients. When we label these stem cells and the mononuclear cells and give them and inject them intravenously, where do they go? This is a huge question in the field. I can answer that question in animals. I can't answer that question, unfortunately, in patients. Not yet, at least. But these cells are labeled in red, and the green cells are actually the rat's own tissues. here. And so this actually is the brain, and these bone marrow cells are labeled in red. So indeed, we do actually see them in the brain. And this actually are in areas right around the damage, right around the stroke. But we found the cells in other areas as well, including in the lungs and the spleen and in the liver. So it's not like it's only going to the brain. Overall, again, another thing you'll have to trust me on, the data that we've acquired, and we're not the only ones, many laboratories around the world have been looking at the use of these cells and other types of cells. But what we are trying and starting to put together as a model to try to understand what cells are doing in the first few days after a stroke, if you were to give some type of, we're calling cell therapy, is the following. We see that these cells are doing a number of things. One, they seem to be releasing lots of different molecules, trophic factors, growth factors, cytokines, things that are involved in a number of different processes, including reducing inflammation, stimulating new neurons, the birth of new neurons, the brain's own new neurons, and also even creating new blood vessels. Now, I want to be careful to say, bone marrow stem cells are not becoming new neurons. This is not about that. We're not actually taking bone marrow and then trying to convert them to make new neurons. What we're seeing is that bone marrow cells release growth factors that tell the brain to repair itself. That's the concept. And that's very important for people to understand. It's not really emphasized in the press or on television what this is about. But this is really where the model paradigm is with the use of cells right now, particularly with regards to bone marrow cells. So because of the data that's been acquired in our laboratories, and also because of data that's been acquired in multiple other laboratories, I particularly like taking forward things where there's reproducibility in other people's laboratories, not just my own. We took this forward to patients as a first study in the US, and I'll argue as a first study that we've seen in the world for patients with acute stroke. We called it the Savitz trial, Safety of Intravenous Mononuclear Cells for Acute Stroke. This was a study in which we were looking at first, and when you do studies like this that's so investigational, you have to start small and start slow and do it in a way that's going to fully satisfy regulatory authorities in this country. So, this was a feasibility study. Could we do this? Can you do a bone marrow harvest on somebody that's actually, in a fragile stage? They just had a stroke in the first few days after, and that's also, it's not just physically incapacitating, it's also just emotionally devastating, not just to the patient, but also to the family. And trying to have a discussion with the family about doing something like this also is complicated and requires time. And so I'm grateful that we actually have a few days to be able to have a discussion with family members about enrolling into a study like this. So this was about a feasibility study and the safety of doing this. Could we give mononuclear cells intravenously to patients 24 to 72 hours after the onset of their stroke? 10 patients is what we did initially, and this is when we did it, from March 2009 to June 2010. Our objectives were, can we do, in this period of time, a limited bone marrow harvest, isolate out these mononuclear cells, give them back intravenously, target dose 10 million cells per kg based on those rat studies. Could we do all this without causing any problems to the patient? That's always the first question when you're first doing an initial clinical trial. And to determine, is this safe? This is just to show you a timeline of this kind of work. That if we find the patients, when they come in, and most of the time when our patients are identified, if they're having symptoms that come on acutely, we have spent 10 to 15 years now in this country educating the public, educating paramedics in the EMS systems to help to bring patients in immediately to the hospital if they're having a suspected stroke. And they come into our hospital, we identify them right away, and then we can find out right then and there, potentially, would they qualify for a study like this or not? And that's what we're doing in this period of time. If we think that they might qualify for a study like this, then we actually start talking to the family, start talking to the patient. We let our bone marrow transplant team know, we let our cell facility know that we may have a patient. Then we do a harvest. That takes about an hour. A separation process of those cells being done in an FDA-approved facility takes about 2 to 6 hours. Then we intravenously give them back, hang it as a bag. I'll show you that picture in a second. And then we're following those patients over time in the hospital. And then we have a goal and a commitment to follow these patients out for 5 years. Why 5 years? Well, there is an ongoing investigation and interest to want to know what happens to patients that get stem cells over a longer period of time. What do these cells do? Maybe it's not just the short term, maybe it's the long term that these cells could have an effect. So that's another reason why we're following them out for longer periods. This is just a cartoon to show what exactly we were doing here. So this is just a picture, skeletal bone here, and all of us, this is the bone marrow, well I should say, this is where we actually do it, which is the iliac crest. So this is the hip bone, and we go in the posterior in the back here. This is something that we have to give some conscious sedation for. We just don't do this without actually making sure that the patient doesn't feel pain. The patient usually is sleeping during this procedure, so it's not general anesthesia, it's conscious sedation. Then we've collected this bone marrow and it goes to a facility that's going to separate out the cells of interest, which are here. And then those cells are purified, it's put in a bag, and we give it back intravenously into the patient. This is a picture of somebody in our study actually undergoing a bone marrow harvest. So I hope I didn't just, sicken anybody here, just showing a little bit of the bone marrow here coming out in this needle, just to show you it's all done under sterile conditions. This is a routine procedure for hematologists, by the way. So what we found in these 10 patients is that we could do this. We can do this, and we can do this with the target goal in mind that we wanted to take out. And it took about 4.5 hours to get the cells back, and we had no severe adverse events that were related to the study in this first pilot study. What happened to these patients? Well, we followed them out for their impairments and their deficits over time, and this is just some data to show what happened to them. This is a scale that we use to measure out neurological deficits. This is a composite score that captures various different impairments on the patient. The extent to which they can't move a limb, the extent to which they can't speak, the extent to which they are having difficulty seeing. This is a composite score that takes all those deficits into account. The higher the score, the worse off the patient. 42 points is actually the highest that you could get on this. A 0 is you completely have no deficits, you're cured. So this is where we were before trial enrollment. When the patients were at baseline, this is the score that they had. They had moderate strokes. And over time, what we see here in these 10 patients, this is the median score overall. We saw this trend in which they went down to here. And this is at 6 months. Now I want to caution that, and I always say this when I'm presenting this data, this does not mean that the cells improved the outcome of these patients. Why? Because this was a single-arm study. And what we don't know is whether these patients could have just naturally improved on their own without actually being enrolled in this trial. So it's very important to bring that up because this was a safety feasibility study. It wasn't designed to be an efficacy study. Is this effective to do this or not? Now, interestingly, we were asked to do this because people want to know, is there any chance that, is there some way that we can answer the question of a hint of a possibility that these people were doing better than what we would naturally expect? Is there a possibility we could look into that? I'm very hesitant about doing things like that because it's very indirect to make those kind of comparisons. But we did it because we were requested to, particularly by the journal that we had submitted the paper to. So this is what we did. We had collected, because we have a registry that we're following of our patients that come into our hospital that we take care of on our stroke service. We collect a lot of information on them. And so we found almost 80 patients that may have met the most basic of the criteria to be enrolled in the study in the 2 years prior to enrollment in the study. And we said, okay, could we create a model that shows what exactly was their natural recovery? And that's what this graph is. It shows, on this graph, we plotted their disability score, which is, this score is a very global one. It's 0 to 6, where 6 is dead and 0 is you have no disability whatsoever. You can see people, for the most part, are somewhere in between. We plotted their discharge disability score versus their 90-day disability score. And this was a linear regression model that we had created. And this is the linear line, as you can see here. So if a patient had a 3 on their disability score, we expected them to be around a 2 at 90 days based on this set of data, based on these patients. It could look very different if we had used some other type of patients. And then what we did was we plotted the 10 study patients on this graph. The dotted lines represents the upper 95% confidence interval of this linear line, this linear regression, and the bottom represents the dotted line here represents the 95% confidence interval on the lower end of this line. And this was all done statistically with statisticians involved in this kind of work. And the only point that I guess I wanted to really show you here is that a lot of the patients were in the range of natural recovery, or they were below, which suggests the possibility, particularly maybe 3, 2, and 1, that they could have done better than those patients that were not enrolled in the study. But that's about as far as I'll take that at this point. And I think it's important, just to basically say, we're not seeing a signal that this is hurting people. And that may be the better way to draw conclusions about such limited work in 10 patients. So what is the next step? Well, we actually took our study of 10 patients and we moved it to 25 because we recognized that 10 is not really enough. Not even enough to say that it's safe. We have finished the 25, and so I can't really tell you what happened in the full 25 because we're in the process of collecting the data, but we're very encouraged by what we've seen so far. And with the 25 patients that we have accrued, we want to really take this to the next level. And the next level is that we need to start determining whether this really does work or not. And the only way to do that is we have to have a randomized study. We have to have a randomized study in which there's 2 arms to it, in which one arm would get their own stem cells and the other arm would not. That's the only way we're ever going to know whether this truly works or not. And that's what we would like to be able to do. There's a lot of discussion around doing that kind of study, which I'm open to anyone wanting to ask any questions about, because I think it's really important to get people's feedback about this. It's really important to get feedback from the community, because it's the patients from the community that would be getting enrolled in the study. We think it would take about 100 patients in order to do this kind of study. It's a phase 2 study, so it's not even the most definitive efficacy study that we could be doing. Really, that's actually the next stage called phase 3. But this kind of study would begin to give us an idea whether this is truly working or not. Now, I did want to mention that I said 24 to 72 hours, and many will say, well, that's not really a very long period of time. And as I was saying, compared to a few hours, it really is quite substantial. But my suspicion is, based on animal data that we have, that this is something that might work maybe within a week at most. That's the best guess that I have based on my reading of the literature. So the question is, can we develop something that could work for something even longer in time? And so that's another area that we are started to work on. We have something that potentially might be able to work even a month out after a stroke. An intravenous injection of a cell therapy purified from bone marrow. Something a bit different than what we are currently doing. Something that would actually require us to purify out stem cells from that mononuclear fraction and grow them in culture over time. And that's where we would like to take that, because of the substantial opportunity that we could actually treat people within 30 days after the onset of a stroke. And so that's something I also just wanted to share with the audience, that we are looking at that opportunity. And of course, overall, we have to be able to find funding for these studies. That's always been the case. In my prior work that we've done here, we were successful and very fortunate that the National Institute of Health had funded us. But NIH funding is very limited to obtain. It gets worse, unfortunately, as time goes on, to be able to find that kind of funding. And so we will have to be able to find it in order to keep this work going. But I wanted to share with you, our excitement, because we think that we're actually starting to see a signal here that really fuels us to want to go forward in time to really build this out more. We think that this really has great potential in order to bring this to stroke patients. And not just for stroke. My conclusions are that this is really, really exciting for the development of novel treatments for stroke, and that we've built this out over time, but it's really not just for stroke. We have been seeing some very interesting findings for traumatic brain injury, which is another obviously important topic under discussion here. And my colleagues down in Houston have been working on traumatic brain injury and have been also seeing some very exciting results in children after traumatic brain injury. They've done a 10-patient study with plans to expand that out, and now they have received funding from the Department of Defense to do an adult trial, patients with traumatic brain injury in adults. So this type of approach with bone marrow cells is not just applicable to stroke, it's also applicable to other brain injuries. And so we're very excited by the opportunity that we could be expanding this out to other conditions. And with that, I want just to thank my team. Overall, this is our UT Stroke Stem Cell team. It's impossible to do any work of this sort without a team. And so I'm here speaking on behalf of all the work that has been done by my colleagues that are down in Houston that are really doing all the work. So thank you really for this opportunity.